Greetings. My name is Anushree Narekuli and I'm an Associate Professor at JSS College of Physiotherapy. Today we'll be discussing about role of exercise in pain management. The overview of the presentation will be discussed under the following headings: chronic pain and biopsychosocial model, classification of pain, physical activity and exercise for chronic pain, definition of physical activity, exercise and physical fitness, central sensitization and characteristics of central sensitization, pain inhibitory effect, mechanism and exercise, application of biopsychosocial approach to exercise as treatment for chronic pain. Coming to chronic pain and the biopsychosocial model, chronic pain can be explained as a complex which includes an advanced interplay between biological, cognitive and social aspects. Treatment for chronic pain should attempt to decrease pain intensity and increase the physical, psychological and social functioning. Why are we concentrating on decreasing pain intensity and increasing the physical, psychological and social functioning? Before we understand this, we need to understand, is there a difference between acute pain and chronic pain? So acute pain is a result of an injury. So after an acute injury, the pain that you develop is known as acute pain. So you have been given any intervention or modalities or exercise or some form of therapy, followed by which the pain reduces. But what happens in chronic pain? In chronic pain, there is no potential tissue damage or there is no injury which is there and the pain still persists. That is known as chronic pain. So if there is no potential tissue damage and there is still pain which is there, that means that there is some amount which has been centralized somewhere in the body. And that is the reason why probably the psychological and the social functioning will come into picture. For example, beliefs. We believe that I will not do an exercise because I may get pain. So this belief that you have is a concept of our thought process, and that is the reason why you avoid doing an exercise. And that may be one of the reasons why understanding a chronic pain may be complex, but we cannot forget that we need to include this aspect in the management of chronic pain. And that is the reason why we came up with the biopsychosocial model in the management of chronic pain. It has been proposed that the biopsychosocial model of chronic pain involves biological factors, it involves the psychological factors, and it involves the social factors. So when we talk about all these factors, we cannot miss either of the factors when we are discussing the management of chronic pain. Now if we look at this diagram here, picture, which we can see that the pain also has influence by attitudes and beliefs. It also has an influence by psychological distress. When you're happy or when you're sad, it may have an influence on your pain. Then looking at illness behavior. Again, if you have some comorbidities like depression, anxiety or any other factors like that, that may also have an influence or effect on pain. And coming to the social aspects. Now example of social aspects are the attributes of in and around. So if somebody is telling you that okay, you get pain if you do a particular activity, and if you believe that is one that you believe, and the other one is the society is also involved in making a decision about pain. So that is one example of the social aspects of pain. Now let's look at the role of plasticity in chronic pain. However, to mention that the role of plasticity in chronic pain is a proposed idea. It is not completely understood or proven that it may be effective in understanding the term chronic pain. If you look at this picture, there is injury followed by an acute pain. Then there is a process of normal healing, which you have a stipulated time after which there is healing taking place and thereby pain relief. But on the other hand, you see healing happens, but you still complain of pain in spite of the healing happening. And that is where the concept of plasticity comes into picture, because there is some amount of change that has occurred in the kind of understanding of pain in your central nervous system, and you perceive that in spite of the healing occurring, you still have pain. And that is called as healing with plasticity. And that leads to two terminologies which are known as hyperalgesia and allodynia. And these two together explains the characteristics of chronic pain. Now there are other two characteristics of chronic pain, which is the temporal summation of pain and the diffuse noxious inhibitory control, also known as controlled pain modulation. Now we look at this diagram. This is the classification of pain. There are various classifications of pain. To make it simpler, I have just put it into a diagram and tried to explain this through three different terms. One is nociceptive pain. Now if you look at this diagram, nociceptive pain is, you can see that noxious stimulus has been given. The nociceptor sensory neuron has been activated and there has been pain. But this pain is an automatic response of withdrawal. It's a withdrawal reflex. So whenever you have pain, you're withdrawing because your system is telling you that there's something which is not right. So you're trying to withdraw that. But what is happening here is it is adaptive. And the high threshold pain is an early warning sign, which means that an acute pain is a protective response. It is a protective response to make sure that you do not damage your tissue, and that is why you have this noxious stimulus. Now the second part is that about inflammatory pain. Now what are you looking at in this diagram about inflammatory pain? There is inflammation. That means that there has been a response, there has been an injury, there has been a tissue damage, and that tissue damage is led to pain hypersensitivity. So if you have an injury, for example, on your arm, so when somebody touches it, do you feel the pain in and around that area? Exactly. That is what is termed as pain hypersensitivity. And that again is adaptive. You can, because there is a tissue that has been damaged and there is going to be a process of healing which is taking place. So it is adaptive, there is a low threshold pain, and there is tenderness which promotes repair, which is again protective. So here in the first one that you saw, it was an early warning sign. It is an early warning system, that is a noxious stimulus. But when it comes to an inflammatory pain, it is a tenderness, or it is helpful in promoting healing, that is a protective response. Both of them were protective. But coming to the third type is the pathological pain. So pathological pain again can be divided into neuropathic pain and dysfunctional pain. So neuropathic pain is talking about there is a peripheral nerve damage. There is a peripheral nerve damage. Again there is hypersensitivity. So if we look at the difference between an inflammatory pain and a pathological pain is that in inflammatory also there was a pain hypersensitivity. In pathological pain also there is a pain hypersensitivity. But there is maladaptive because you have understood the pain in a wrong manner. You have got adapted to wrong aspects or wrong perception of pain. That is why it is maladaptive. Again, it is low threshold pain and it is disease state of the nervous system. It is understood as a disease state of the nervous system. Coming to the dysfunctional pain again is pain hypersensitive, but there is no positive symptoms. There is no inflammation and there is no neural lesion which is there. Still, there is a pain that has been perceived by the individual, and that is because it is maladaptive, it is low threshold pain, and again it is a disease state. And that is why the pathological unit is termed as chronic pain. Now why do you think this happens? This is because there has been some sensitizing or maladaptive understanding of the pain in the central nervous system, and that is called as the central sensitization. So you have a peripheral sensitization followed by a central sensitization. So central sensitization or sensitization is a neurophysiological term that describes the increased responsiveness of nociceptive neurons to their normal input. That is, the pain pathway becomes more sensitive than normal as compared to the normal individuals. This can include a drop in the threshold for activating primary efferent nociceptors and an increase in the frequency of firing for all stimulus intensities. So clinically, sensitization may only be inferred indirectly from the phenomenon such as hyperalgesia and allodynia. So if I have to say that this patient is in chronic pain, how will I define it? It is very difficult to say that this. So the only phenomenon that can indirectly explain the central sensitization is through hyperalgesia and allodynia. Now we look in the next few slides about what we understand by the term hyperalgesia and allodynia. Before that, let's look at how there has been a change from acute pain to chronic pain in the central sensitization phenomenon. Acute pain is more tissue nociception and less brain pain, while it has extended to come into chronic pain, which is less tissue nociception and more brain pain. Now let's understand this more scientifically. When we look at this diagram, there is increased peripheral input. Now this increased peripheral input is led to the brain through the spinal cord activity, and there is increased awareness of noxious events. So even a small, it will be painful. If there is a pinprick, you may feel the pain, but it is perceived as more pain, and that is what is termed as chronic pain. Now how does this happen? Because this is altering in the central processing system at the brain and at the spinal cord level, leading to secondary hyperalgesia and allodynia. So from this diagram, what do you understand? If you can look at the diagram on your left hand and on the right hand, it was a very painless stimulus. So it's a feather, but still you feel that there is a painful stimulus. Now this, when it is a painless stimulus and resulting in a painful stimulus, the individual perceives it as a painful stimulus, is termed as allodynia. And what is hyperalgesia? Hyperalgesia is a heightened or increased sense of pain to a noxious stimulus. That means to a painful stimulus when there is an increase in magnitude of perseverance or perception of pain, it is termed as hyperalgesia. What is temporal summation of pain? To give you an example of temporal summation of pain, this is a patient who has got osteoarthritis and is trying to we are giving her exercises of quadriceps. So we are telling her to do knee extension and flexion. Now as you see that there is, you can see some amount of red line, that is called as pain. It is pain. She has pain right now. But now with every repetition, so we are not changing the intensity, we are not changing the weight, we are not changing anything. Everything is constant. She's just been asked to do repeated quadriceps exercises of knee flexion and extension. Now what is happening is, there is an increase in the intensity of pain or perception of pain. Every time that she's doing it, she's perceiving the pain more and more. And this is termed as temporal summation of pain. So what is happening in patients with chronic pain is that they perceive the pain. There is an alteration in chronic pain patient. There is alteration in the temporal summation, and that is the reason why you feel that there is more pain with every repetition. So every time that you do a repetition, you feel an increase in the pain. Now coming to diffuse noxious inhibitory control. Now in diffuse noxious inhibitory control is that normally what happens is, if any part of the body you have been giving a painful stimulus. So if you have a primary pain, so there is a primary pain that is already existing, and suddenly there is a secondary pain. For example, I have a primary pain of knee on my right knee, and suddenly I injure my ankle on the left side. So what happens is, you understand the noxious, that is your secondary pain is more than your primary. So this is what is normally seen. But in patients, what happens is, again there is alteration in these controlled diffuse, in this controlled pain modulation. There is a problem with the controlled pain modulation, and that is what is known as diffuse noxious inhibitory control. Now what we have seen is, a number of chronic pain conditions are associated with a loss of conditioned pain modulation and increased temporal summation, and thus lack of immediate effects of exercise or even increase in pain with acute exercise could be explained by this lack of inhibition and enhanced excitability of the Now, if there were studies which were done where they saw that patients with chronic knee osteoarthritis were given a particular amount of therapy. So, patients who were given exercises and their pressure threshold. So, people who had conditioned pain modulation had increased pressure threshold to pain, while the ones who did not have a conditioned modulation of pain had less threshold to pressure. Okay, less pressure threshold. Now, physical activity and chronic pain. Do you think it is important to do exercises in pain? Yes, it is actually important to do exercises. The old mindset was that you need to give rest and do not have to do any activity. So for many years, the choice of treatment for chronic pain was rest and inactivity. But that is not true. To give you an example, if I ask you, you can do this at when you're doing an activity as an activity. You can just sit in a particular position, maybe cross-legged or maybe in Vajrasana for a period of about 10 minutes, 15 minutes, half an hour, and you'll see that after some time, you would want, you just see the response what you get. Normally, the response is that you would want to change your position, can be one response. You would want to either get up and walk around and do some movement, or you would want to just stretch yourself with whatever activity, in sustained activity. Which means that a sustained activity for a longer duration will lead to some amount of pain. And to relieve that, you need to do some movement. And when you say movement, it is some kind of physical activity. And that is the reason why it is important for you to move and do not stay. So when it is coming to chronic pain, isn't it very important for you to move around? Yes, it is very, very important that you move, or there is some amount. But there can be an alteration in the intensity, in the duration, in the mode that you choose for an exercise. That can be individualized, because it is very, very difficult for you to decide a common protocol, because every individual will have a different response. So based on the individual response, you can plan a structured exercise program for individuals. So exercise not only reduces pain perception, but also has effects on mental health, such as mood elevation and reduction of stress and depression, which are often associated with chronic pain conditions. Physical activity and exercise are associated with minimal adverse effects. I'm sure all of us would agree with this, that there are very minimal adverse effects. For example, in case of rheumatoid arthritis, where there would be protection of the joint. Maybe you will have to protect the joint, but at the same time, there would be mild amount of exercises that you would do. You still do some movement. You would not say that you do not do any movement at all. Right? So current evidence suggests that simply giving an individual advice to exercise is insufficient to bring about significant change, and a badly prescribed intervention that does not consider the individual's condition and present state of health and fitness may flare up the symptoms. Now, what do you mean by this? That means that we know that the gold standard that we follow is American College of Sports Medicine. So whenever you're planning an exercise program for whatever condition it would be, the framework that you use and abide by is the gold standard. And within the framework, you can always do a permutation or combination of protocols that you would follow. But if it is underdone or overdone, both of them can be equally harmful or ineffective in the treatment. And that is how the results may not be appropriate as desired. Physiological actions along with behaviors are important in the treatment of chronic pain. Now, physiological actions along with behavior. So what do we understand by this? That whenever you are exercising, don't you think that if normally also, if I have to exercise, so I say that we have to exercise every day. How many of us do really regular exercise every day? So for example, I will do it for a week, and after a week, there would be somebody who may say that, no, I had some work because of which I cannot do, or I had some other commitments because of which I couldn't do, or the equipments were not available, or I don't have a proper place to do the exercises. So you would have various reasons, or may genuinely have a problem with exercising, which means that there is some behavioral component involved. Yes, we all agree that there is some amount of behavioral component associated with exercise. That means that it is just not physiological actions, but also the behavior is important in the treatment of chronic pain. Especially when they don't know, when you know that, they say that they go to various doctors and they say there is pain, but there is no potential tissue damage, or there is no potential reason why they would have chronic pain. In that case, the patients are really wondering, why do I have this pain? The question that every chronic pain patient would have, why do I have this pain? If there's no problem, why do I have this pain? Which means that there is some amount of behavioral modification or alteration that we need to work on. Okay, that's the reason why behavior is an important concept in treatment. So behavior is described in terms of overt behavior or covert behavior. What is overt behavior? Overt behavior is actions that is observable by others. Example include the performance of prescribed exercise in a proper way, or the adherence to an exercise regime, that you have to adhere to a particular exercise regime. So normally, again another example to ask, that if I have pain, I go to the doctor and I say I have pain. So the doctor says, okay, you need to take a particular dose of drug followed by exercises. So I take the dose of drug followed by exercises. So once I feel there is relief, how many, in your clinical settings, how many of you experience the same thing, that after the pain is relieved, and you said that you have to come for about 6 weeks, but the patients may interrupt their pain therapy in between and not follow it up for those 6 weeks. Because when you ask them, when you call them up and ask them, they would say that, yes, I have relief of pain, and then I was busy also, so I couldn't come. That means that the adherence to the exercise program may not be very complete. And that is very important when you are taking in consideration with chronic pain or any other exercise. That completing your set duration of exercise for an effective result is very imperative. Now the other one is cohort. Covert behavior is actions that take place within an individual, such as thoughts or emotions. For example, fear avoidance, anxiety, and pain acceptance. So now I have already, so how many of you all have fear of taking injections? How many of us would have fear of taking injections? Is that everyone will have fear? So you have some emotion or some thought process which is linked to why you are scared of taking injections. And that is what is called as an emotional component. So there is some factor which is there, which is preventing you from taking. So there may be some factor, some people who may say that, no, I do not want to take it. Whatever happens, I'm not taking it. While the other group of people may say they're scared, but they still try to overcome the fear and go ahead and experience it of what will happen this time. And this is called as coping strategies and non-coping strategies. So some individuals have the ability of coping, while the others may not have the ability of coping. And that is where the medical intervention may have to pitch in. Now we would like to look at, when we are talking about, we spoke about the physiological effects of physiological effects is equally important as we look at the behavioral component. So now we have been looking at a lot of articles, and what we have realized, or the literature says, that physical activity, do you think physical activity and exercise are the same? If so, they are not. But in literature, when you look at it, most of the times they use interchangeably. But let's look at the actual definition of physical activity, exercise, and physical fitness, which may help all of us in planning an appropriate exercise program. So physical activity is defined as any bodily movement produced by skeletal muscles that require energy expenditure. So any exercise, any activity that you do which demands your skeletal muscles for energy expenditure is termed as physical activity. Coming to exercise, on the other hand, is a subset of physical activity characterized by planned, structured and repetitive physical activities with an objective to maintain and improve physical fitness. That means, now what do you understand by this? Physical activity can be anything. You just go for a walk with your friends, that can be a physical activity. You do, you do mopping, or you do sweeping at home, that is also called as a physical activity. But that does not mean that is an exercise. So exercise is when you have a structured plan, or when you have something which is repetitive. So you're doing it for a longer duration with some intention in mind. So what is the intention? Of improving your current physical fitness. If you're saying the current physical fitness, what does physical fitness mean then? So physical fitness is a set of attributes that people have or achieve that relates to the ability to perform the physical activity. Right? How will you do this? Through a particular set of components, and that is known as physical fitness. So physical fitness components can be divided into health-related physical fitness components and skill-related physical components. Under that, again, you have health-related physical fitness components have, you talk about flexibility, you talk about endurance, you talk about strengthening, and you talk about coordination, and you talk about, so on and so forth. And again, when you talk about endurance, you have two types of endurance. You have muscular endurance and you have aerobic endurance. So now the other thing that you would include is also your BMI. That's also an important component. Yes. Now looking at what are the benefits of exercise. Why do you think we are talking about exercise and all that? So what are the benefits of exercise? So the benefits of exercise are, it helps with your strength, it improves your strength, it improves your flexibility, it improves your endurance, that is your muscular endurance and your cardiovascular endurance. It is decreasing the risk of your cardiovascular conditions. It has better effect or better influence on your bone health. There is decreased metabolic syndrome, the potential decrease in metabolic syndrome. There is improved in cognition. There are studies, there are numerous studies which support the evidence that exercise also helps in improving your cognition, directly and indirectly. You also have these days mental exercises, and that also does improve your mental cognition. Then there's an improvement in the mood, there's improved pain control, which is the topic of the day. Improvement in the control. But to do all this, what you need to do? You need to be planning an exercise protocol, following it. Which means that now, I'm sure that all of us have understood that physical activity alone may not really be useful in the treatment of pain. It is not a single dimensional intervention, but it is a multi-dimensional intervention approach that we need to use in chronic pain. Now we are looking at the pain inhibitory effect mechanisms and exercise. So exercise activates endogenous analgesia in healthy individuals. Okay. So what is exercise-induced hypoalgesia? This is an acute effect of exercise. Okay, this is proposed through or termed through exercise-induced hypoalgesia. So the proposed mechanisms are, it works on the descending pain modulation pathways in the central nervous system. The second mechanism through which you can achieve exercise-induced hypoalgesia is release of endogenous endorphins, and the third one is regulation of BP and pain inhibition. But this third concept is not very well explained in literature. So it's still inconclusive about whether it really has the effect that it is explaining, or it is just a understanding or proposition. The increased pain threshold following exercise is due to the release of endogenous opioids and activation of the supraspinal nociception inhibitory mechanisms outstretched by the brain. Exercise triggers the release of beta endorphins from the pituitary, that is the peripheral system, and the hypothalamus, that is the central system, which in turn enables the analgesic effects by activating the opioid receptors peripherally and centrally. But on the other hand, hypothalamus through its projections activates, that is through the projections on the periaqueductal grey matter, it has a capacity to activate the descending nociceptive inhibitory mechanisms, which means that what are we looking at here? Two mechanisms have got activated. One is the opioid system by means of the peripheral and the central, that is the pituitary and the hypothalamus, and the other one is a non-opioid system, that is through the hypothalamus projection on the periaqueductal grey matter, which is stimulating the activating the descending nociceptive inhibitory mechanism and thereby relieving pain. Now here, if you see, this is an exercise driven alteration in the sensory nervous system. So when you look at this, you can see there are changes occurring at every system with exercise. So what is happening here is there is normalization of the TRKA receptor positive fibers. There indirectly what is happening, there is increase in the epidermal innervation and decrease in the nerve growth factor. The other one is axon. At the axon level, what is happening? There is increase in the axonal growth. There is increase in the glial derived neurofactors and the brain derived neurofactors. Okay, and there is also increase in the cell proliferation. Then at the DRG or the dorsal root ganglion. In the dorsal root ganglion, again there is increase in the BDNF and decrease in the nerve growth factor and also decrease in substance P, very important. Okay, coming to the DRG, after DRG you look at the spinal cord. Spinal cord, what is happening? There is increase in the GDNF and also there is increase in nitric oxide in the cerebrospinal fluid. Initially they had assumed that it does have an effect on pain modulation. Yes. And then coming finally to the brain. What is happening in the brain? There is decrease in the NMDA receptors which are responsible for pain. Okay. Also increase in the endogenous opioid system, which we have already seen, and also the non-opioid system through the periaqueductal projections on the periaqueductal grey area and through the that is activating through the descending pathways. Now we are coming to the application of the biopsychosocial approach to exercise as treatment for chronic pain. So what are we looking at in this act? So evidence suggests that pre-treatment. Now when we are looking at exercise, let's come to we'll start with initial assessment. Do you think initial assessment is is important? Yes, it is very important because as we said that there are a lot of factors which are involved now in the treatment of chronic pain. So can we repeat it again? So what are the factors which are involved? The factors that are involved are just not the biological but also the cognitive and the social, which means that the cognitive and the social concepts, the components. How will we understand about the cognitive and the social components? Only through interviews or through standardized questionnaires. But how will we understand about the standardized questionnaires unless we evaluate the patient? That means that initial assessment for understanding chronic pain with all these factors is very, very important. So that is why evidence suggests that pre-treatment expectation significantly influences the treatment outcomes, including pain and disability. Right? Then when you're doing a goal setting should be planned before commencing exercise. That means you should understand what are the patient's expectations and what is your expectation, because sometimes you may not be on the same page. For which we need to look at the goal settings planned before commencing exercise and involve a collaborative approach. Physical activity and function along with the other biopsychosocial aspects, which is very, very important. Right? Now coming to fostering treatment expectations around improving function, quality of life and reducing. Now this is a very, very important understanding. Okay. So now when we look at acute pain and chronic pain, the difference in the management is very important to understand. What happens in acute pain is, there is a potential tissue damage. So you understand that there's something which is happening and you treat it. That means that what do you respect here? You need to respect pain. You need to respect VAS in terms of acute pain. But on the other hand, in chronic pain, there is no potential tissue damage. It is because we are understanding that the central sensitization phenomenon, we do have pain. So if we have this, what are we doing? We need to look at the aspects, a complex interaction of biological, social and psychological components. But when we are doing this, what we are doing, do we have to look at pain? Pain may not be a useful indicator, because patients with chronic pain may not see an immediate effect on pain. So if you take that as an outcome, the patients may again feel that there was no improvement and may just say that I do not want to exercise. So here, with this understanding, what will our outcome be? The outcome should be function. The outcome should be quality of life. Improving function and quality of life should be your primary goal. And the secondary goal can be pain. Because once the patient starts exercising, literature also supports this process, that exercise and movement will start having an influence on pain, and thereby the pain will reduce. But pain should be a secondary outcome in the treatment of chronic pain. So the exercise that you see impacts all the musculoskeletal, the cardiovascular and the brain, right? But when you look at all these, the two factors are, you can treat them through exercise, and both these factors can have an influence on the brain, does have a positive influence on the brain. With this, we come to the end of the session. Thank you.